Alright, hello online students. I will be doing part 2 now of our adventure of diabetes mellitus. Research, research, research actually supports that the key to prevention of long-term complications of diabetes is keeping your blood sugar levels and cholesterol levels as close to normal as possible. So all these micro and macro complications that we're going to talk about, if a diabetic would keep their sugar normal or near normal, then they would actually prevent those complications from occurring. So I'm going to minimize here and then I will pull up my PowerPoint. All right, diabetes mellitus part 2. And we are going to be talking quite in depth in this part about several things. So let's start off talking about the etiology, type 1. Type 1 was formerly called insulin-dependent diabetes mellitus or juvenile onset. And the reason we quit calling that, it actually changed in 1997. And it changed from insulin-dependent diabetes mellitus to type 1 diabetes because we were finding there were some people with type 2 that were becoming insulin dependent. With this type, there's a destruction of beta cells. This is thought to be, but not proven to be, an autoimmune destruction. That means the body turns on itself. That's why in part 1 in that chart that compared them, it said the antibodies would test positive, and that's because of the autoimmunity. HLAs, if you'll remember with type 1, HLA typing was common. And with HLAs, there's a strong association of type 1 with 3 particular HLA types: HLA-DR3, HLA-DR4, and HLA-DQ. There may be genetic defects of the beta cells that cause destruction, but the most common reason in children is viral destruction. And the most common viruses can be cytomegaloviruses, Epstein-Barr, the mumps, and hepatitis. What happens is the virus attacks the islet cells of the pancreas and renders them useless for producing insulin for some reason, especially in young children. And of course, that's going to lead to type 1 diabetes. In the child, if you have a child who has just one of those markers, DR3, DR4, or DQ, they have a 2 to 3 times greater risk of having type 1 diabetes. If they have 2 or more of those markers, they have up to 10 times risk of having diabetes. So the more markers you have, the more risk that you have of getting it. It occurs more frequently also in white Americans. So let's look at type 2 diabetes. And the new terminology is diabetes plus obesity equals diabesity. So that is the new terminology for type 2 diabetes. And these are the ones that are obesity, and they are obesity-dependent diabetics. They tend to stay obese. Now, type 2 was formerly called non-insulin-dependent diabetes mellitus. 90% of people with diabetes have type 2. Only 10% have type 1. There is a strong genetic component with type 2, but no HLA typing. In other words, there's no particular HLAs that they have that make them more prone to it, but there is a strong genetic component. Increased among Native Americans, African Americans, and Hispanic as compared to Caucasians. And the main risk factor is obesity. Obesity decreases insulin receptors in the tissue, and that leads to insulin resistance. Now, obesity is defined as more than 20% above ideal weight, because what happens is the more they eat, the more insulin they need to metabolize that glucose, and they can't keep up with it. And with age, insulin resistance gets worse anyways and increases. So there's no supply for the high demand. So let's think about it. Why is diabetes occurring more frequently? Well, we have longer life expectancies now. Obesity is increasing among the general population. Children of diabetic parents who themselves develop diabetes. Sedentary lifestyles. And the fast food craze is particularly the all-you-can-eat. So there are several reasons why diabetes is occurring more frequently. Longer life expectancy, obesity is increasing, children of diabetic parents who themselves develop diabetes, sedentary lifestyles, and fast food craze, particularly all you can eat. Now, the interaction between genes and environment. Genes actually load the guns. So we're born with certain genes that loads the guns. But the environment you choose along your life path is what pulls the trigger. So in other words, you may be prone to type 2 diabetes, but if you watch your diet, you exercise, you keep your weight down, then you are more or less likely to actually develop type 2 diabetes. But you can take that environment and actually pull the trigger and develop diabetes. Incidence. There's about 20.8 million Americans living with diabetes, 18.7 have type 2, so about 90%. 200,000 die yearly of complications with 1 million new cases every year. Now that's staggering when you think about the cost of diabetes. It's actually the 7th leading cause of death in the United States. As far as predictions and research, over the next 4 decades, they think there will be an increase of 165% in diabetes. So what does that mean? We need more educated nurses regarding diabetes, and that's part of the reason we spent part of our STEM lab doing nothing but diabetes dietary management. It is an increase in children as well. We are seeing them diagnosed at the age of 4 now, particularly even with type 2 diabetes. Very scary. And I've given you a website here if you want to go to it later on the CDC website that gives you some more staggering statistics. So who should be screened? Well, all individuals, particularly those, though, who are greater than 45, especially if your BMI is greater than 25, and you need to be tested with a fasting plasma glucose level. If it's normal, then they change that and recommend screening every 3 years. Now, children who are overweight, whose BMI is greater than the 85th percentile, and they have other risk factors such as family history, race at a high risk, or conditions associated with insulin resistance or maternal history of diabetes or gestational diabetes mellitus, should start at about age 10. Testing again with the fasting plasma glucose, if normal, every 3 years. So these are the screening guidelines to detect diabetes. Yes, screening is a secondary level of prevention. If you see the word screening, think secondary level of prevention. There's also a complete list in your MedSurg book if you want to look at it on page 1418. So you can look at that and glance at it as well. Now, let's talk about something else. Let's talk about abdominal fat. Now, this is a little fuzzy, but you can still tell the shape. It says heart disease and diabetes. Who's at more risk? A pear or an apple shape? And you can see here that which one would be at more risk. Apples. So if you've got that rounded apple look, then you are more at risk because of the abdominal fat. And that leads to heart disease and diabetes. So the shape of your body even makes a difference when you're a diabetic if you're shaped more like a pear or more like an apple. So that's why the poor apples have harder time losing weight than the pear shapes. Now, SCAT versus VATS. SCAT it stands for the subcutaneous adipose tissue. And that's the fat located immediately beneath the skin, or the skin. Then you have the VATS, which is the visceral adipose tissue. And that is fat located in the body cavity beneath the abdominal muscle. So, let's think about this. Pears and apples again. Okay. Pears, for the most part, are SCATs. They have subcutaneous adipose tissue and the fat's immediately beneath the skin. Whereas most of your people that are apple-shaped, not all of us, but a lot of our people who are apple-shaped are VATs. Okay? Now, the way I think of a SCAT is more like a jelly belly. Okay? So what do you call a person who's shaped like a SCAT? A jelly belly. Now, a VAT is those bellies that you've seen, that visceral adipose tissue that have that very rounded stomach that's hard as a rock. Have you ever bumped into someone that's got a large stomach and you think, man, that was hard? You can almost bounce a quarter off of it. They are considered VATs. And VATs are the ones that have the visceral adipose tissue that's located right underneath actually the abdominal muscle, and they are more at risk. So you have to know if you're an apple or a pear and a scat and a VAT, and or if you're a combo. Some people are shaped kind of combo-ish. So what's other risk factors? Okay, if you look on page 1417 in your book, it does talk about metabolic syndrome right at the top, also known as metabolic X. Now, this is not a disease, metabolic syndrome. This is a collection of health problems that set you up for diabetes. So it's risk factors to watch for. So the metabolic syndrome, also called metabolic X, and consists of these 5 areas, starting with abdominal obesity. If your waist circumference of 40 inches or more for men and 35 inches or more for women, that's one risk factor, abdominal obesity. More than 40 inches in women waist circumference, in men, more than 35 in women. Fasting, blood sugar elevated, 100 or 110, depending on what book you look at. So fasting blood sugar greater than 100 to 110. Hypertension, blood pressure greater than 130 over 85 now. And that is someone that's even on drug therapy for high blood pressure if they're still running greater than 130 over 85. So blood pressure is running greater than 130 over 85. And then you've got your triglycerides. And your triglycerides are greater than 150, you will be at risk. Or if you've got more HDL cholesterol, less than 40 for men and less than 50 for women, that's a risk factor. If your HDL is less than 40 in men or less than 50 in women. So again, this is not actually a disease process, but it is a way that if you have these risk factors, then it's leading to metabolic syndrome, which leads to diabetes. Healthy People 2010 had 3 main objectives: to reduce the diabetes death rate to no more than 12 out of 100,000. Don't think we're doing too good there. Reduce the frequency of foot ulcers in people with diabetes. I think we are becoming more aware of it and doing more things to help with that. Increasing up to 52% of the persons with diabetes who receive formal diabetic education. And that's been the one we've mainly focused on. That's why we've got diabetic nurse educators now. So I think we're doing overall somewhat good in some areas, and in other areas we're not doing as well. Breastfeeding. Breastfeeding in a diabetic lecture. Oh my. A review of 7 studies concluded that breastfeeding lowers diabetes risk by 15 to 56%. So another reason to breastfeed. Breastfed babies are less likely to be overweight as children and adults. Another reason to breastfeed. The American Academy of Pediatrics recommends exclusive breastfeeding during the first 6 months of life and actually urges mothers to continue that for the first year. Don't think that's going to happen though. So breastfeeding, absolutely, is good for you. So what is the diagnostic criteria for diabetes? 1, fasting plasma glucose, and that would be greater than 126 milligrams per deciliter when you've been fasting for 8 hours. Okay, this is diagnostic criteria for actual diabetes. 2, a random plasma glucose any time of the day that's greater than 200. 3, an OGTT, oral glucose tolerance test, greater than 200 in 2-hour sample of a 75-gram loading dose. So you give someone a 75 loading dose, you keep checking their sugar, and at the end of the 2-hour sample, if it's still greater than 200, then they failed. Hemoglobin A1C, greater than 6.5 or higher now. It used to be 7, and recently they have dropped that down to 6.5. Then you have the IGT, which is the impaired glucose tolerance. It used to be called our borderliners. Now, most people carry, there's no such thing if you got diabetes or you don't have it. In fact, 25% convert to type 2 diabetes within 10 years of being what we call IGTs or borderliners. Your fasting plasma glucose, again, 100 to 126 would be considered a borderliner because remember, greater than 100 was considered high, and greater than 126 is actually considered diabetic criteria for diabetes. So if you're between those two numbers, you're considered a borderliner. If in 2 hours, if you check your 2 hours and it's greater than 140, but it's less than the 200 that's required to be a diabetic, then you are considered to be a borderliner. So what do you do? Prevention, prevention, prevention. We take these screening tests, we use them for teaching, and we try to prevent them from becoming full-blown diabetics. Glycolated hemoglobin or hemoglobin A1Cs. Now, I don't like these little tattletellers, and that's what you call a hemoglobin A1C, because years ago, Grandma used to eat that big old piece of pie and have herself a field day and take her insulin when she was eating the pie. And right before she got ready to go to the doctor, she would straighten up and do good for a few days so that when she went in to get her sugar checked, it wasn't too bad. Well, now hemoglobin A1C actually averages what you've been doing over the previous 3 months. So there's no more cheating. Hemoglobin is a protein in the red blood cells that carries oxygen to your tissues. Since the red blood cells live about 120 days, a hemoglobin A1C measures the diabetic control for the previous 3 months. Normal results are 4 to 6% in the non-diabetic, and in the diabetic, greater than 6.5. Now, your goal when you're taking care of diabetics is that they stay below 7%, but they're diagnostic if they're greater than 6.5. Anemia can cause falsely low levels. So if someone's anemic and you're checking their hemoglobin A1C, that can be a false low level. Blood transfusions can affect results depending upon whose blood you got. And you want to monitor this about 3 to 4 times a year. Now, they also have a new testing, hemoglobin A1C at home. The FDA has looked at the accuracy of it, and there has been known to have some accuracy to it. So it's a little fast, accurate device that lets patients measure their hemoglobin A1C at home. It did, again, receive FDA approval. It's about a pager-sized monitor, and it measures both your hemoglobin A1C, your total hemoglobin, from a finger stick. You'll get your results in about 8 minutes after you do the test. Okay. Now, comparison of hemoglobin A1C to blood sugar readings. If your hemoglobin A1C comes back and it's 7%, that means you've been averaging your blood sugar level about 154, okay? If you come back and it's a 9%, that means you've been averaging about 212, okay? And you can see here, even at 6%, you're averaging 126, which is diagnostic criteria for diabetes. So anything over 6.5, we're really getting concerned about being a diabetic. And of course, 12% is 298, and it continues. And I have seen some hemoglobin A1Cs come back quite high. So what's new in blood sugar meters? Well, they're simpler to use than years ago. They do have quicker results. They're easier to collect blood samples. They're portable. They got a good memory. They're smaller. They use a smaller blood drop, and they do support data. In the future, they may be able to measure hemoglobin A1Cs non-invasively by inserting a finger into a probe similar to your pulse oxes. And that's been a big thing that they've been working on in years, because of the biggest complaint in noncompliance is that, diabetics hate to have their fingers poked and poked and poked. They get sore after a while. Clinical manifestations, type 1. Well, we talked about this earlier. Abrupt, the 3 Ps. Polydipsia, polyuria, and polyphagia, weight loss, and fatigue. What's the rationale for these signs and symptoms? Polyuria is caused because of the osmotic diuresis. The amount of glucose filtered by the kidneys exceeds what's absorbed, so therefore you diurese. Polyphagia, well, you deplete the cellular stores of carbs, fats, and proteins. They are hungry, and that leads to cellular starvation. Polydipsia, the high blood sugar levels, again, leads to osmotic diuresis. That leads to intracellular dehydration, so it stimulates thirst. And then weight loss, again, related to the osmotic diuresis and the loss of body tissues. Protein and fat breakdown is secondary to the lack of insulin that results in weight loss. Fat breakdown leads to an increased production of ketone bodies, and these are the byproducts of when fats broke down. So you break fats down, you lead to ketones. Ketone bodies actually disrupt the acid-base imbalance of the body, leading to metabolic acidosis, or what we call DKA. And DKA. So the acid-base imbalance you would watch for with diabetics is metabolic acidosis, and usually that's secondary to DKA. When fats are used as your primary source of energy, that's not good. A lot of lipid levels floating around, and they increase up to 5 times their normal, so that puts you for other risk, cardiovascular risk factors. Clinical manifestations for type 2. Well, there's sufficient insulin. Remember, they don't have total destruction of insulin to inhibit the development of DKA, but they get what's called HHNK, hyperglycemic, hyperosmotic, non-ketotic syndrome, or coma. Recurrent infections and delayed healing are very common with type 2 diabetes. Genital itching, pruritus, especially hyperglycemia because it favors fungal growth, yeast infections, candidial infections. Visual changes, blurriness, paresthesis, neuropathies, and we all check for neuropathies. Fatigue, metabolic changes, obesity, hyperlipidemia, hypertension, and usually over 30 years of age with type 2. Now, a red flag in adolescence may be the recurrent vaginal infections and UTIs. Some studies have shown that the onset of type 2 diabetes actually occurs at least 7 years before it's diagnosed. That's kind of scary. You're actually having some signs and symptoms of diabetes 7 years before it's actually diagnosed with type 2. Other forms of diabetes would be pancreatic diseases that lead to beta cell destruction, drug and chemical-induced beta cell destruction, genetic syndromes like Turner's, and gestational diabetes, and lastly, not on the list, but cystic fibrosis as well. And we'll talk about that when we talk about respiratory. Treatment. With type 1, insulin replacement is required. There is no average dose. This varies from individual to individual. Insulin is exogenous and has only been used since 1922. Human insulin is the insulin of choice. Your strengths come in U30, U40, U50, U80, U100, and U500. U100 insulin is almost always used in the United States. That means for each meal, there's 100 units of insulin in that syringe. Make sure you're using the correct insulin syringe. Insulin is broken down by gastric enzymes. That's why we can't give it orally. Now, there's no cure for diabetes, so the overall goal is going to be to regulate and control glucose levels rather than cure them. You also need to keep in mind that human insulin may have a shorter duration and onset than your beef and porks, and almost all physicians have converted over to the human insulin. Why did we switch to human insulin? Because the exogenous insulin came from the pancreas of pigs and cows. Well, that's foreign to the body. That leads to insulin allergies when we were using the beef pork. But now the human type, we don't see that. So that's why they switched over. So, types of insulin. You have your onset, peaks, and duration. You got your rapid and your Novolog, Humalog. Those are mainly your logs. Your short-acting, your Rs. Your intermediate-acting, NPH, Novolin, and Humulin, and then your long-acting, Ultralental and Lantus. Okay? I know these amounts differ slightly from page 1431 in the book, but go by this table for exam purposes. Hint, 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 hint. Okay? So, if we think about the rapid-acting, this group, of course, the insulin is clear when you look at it. It has an onset of 5 to 15 minutes with a peak in 30 to 90 with a duration of 3 to 4 hours. Your short-actings are also clear, 30 minutes, 2 to 4 hours, 3 to 6 hours duration. Now, if you think about the onset of action, 5 to 15 minutes, We call the wrapping acting ones. So when you give Humalog or Novolog, they need to dose and eat. Dose and eat because of the rapid onset of time. These need to be given about 30 minutes prior to eating breakfast because the onset's going to occur in about 30 minutes. Intermediate acting, these are your cloudies. Okay. They have a longer onset, peak, and duration. The ultra long-lastings, Levemir, Atlantis, Ultralantis, are also clear. They come in a taller bottle, but they're clear, so that's confusing to some people. Make sure you're giving the right insulin. Onset 2 to 4, no peak, and 24 hours plus. Okay. Now, one of the things that you want to keep in mind is that when someone is getting ready to give insulin and wanting you to double check it, because we always double check when we give insulin, is that to make sure they're giving the right insulin. What if someone brings you a syringe and says, I'm giving 10 units of Humalog, okay? And it's clear and you look at it and you say, okay, go give it. But they were actually giving 10 units of Lantus because they did not have the bottle and they didn't have it in the bottle. Even if someone brings you the bottle and shows you the syringe and says, here it is, this is what I drew up, I would not trust that. I would want it inside the bottle, still in the bottle when they show it to me, where it's at, so that I know that's exactly the right insulin. So no, this chart, no, this chart. Oh, example question. The RN is teaching a 15-year-old client about the different types of insulin. The client states or takes NPH insulin at 8. So he just took some NPH at 8. The RN interprets that the adolescent understands this type of insulin when the child states that the most likely time for an insulin reaction would be A, while working out at 9 a.m. B, while taking a test at 10 a.m. C, while eating lunch at noon. D, while golfing after school at 3 p.m. And the answer, if you went back and looked at your chart, NPH, let's see, the onset is 1.5 to 2, but it peaks in 6 to 12 hours. So if it peaks in 6 to 12 hours, the answer is D, while golfing after school at 3 p.m. So that's kind of questions I'll ask. We also have combination insulins, which is like our Humulin 70-30, which is 70% NPH, 30% regular. Humalog 75-25, which would be Humalog 25, insulin Lispro or NPL, very similar to NPH. And the only kind of insulin given IV is regular. Regular short-acting should be the only kind. Now, there's a few physicians that will give Humalog, but really regular is the kind that's given IV. The proper way to verify with another nurse, I just went over that with you. So what's some fast facts about insulin? Insulin in use may be at room temperature up to 4 weeks. All other insulin should be refrigerated. Now, if you're using the pens, you don't have to refrigerate the pens. If mixing regular with Lantus or Ultralantus, give the injection immediately. Lantus cannot be mixed with anything. There's no need to aspirate anymore, they say. Hold pressure after the injection, but do not massage. It affects the metabolism of insulin. So these are some fast facts you need to keep in mind. Now they have sliding scale insulins, mainly when the patient goes in the hospital, and they will be either a low, medium, or high dose. And you will have to find out what dose they ordered and go by that sliding scale according to the Accu-Checks. Now, a lot of ICUs have actually started protocols where they put particularly people who's had surgery on insulin drips because the better you keep their sugars closer to normal, the better they heal. And there's a lot of research and articles out on that as far as making protocols for insulin for ICU patients. The use of subcutaneous insulin, mixing of 2 insulins. Well, you're going to rotate if you had NPH or intermediate or long. Then you're going to draw back the amount of air into the syringe that equals the total dose. Inject it into the intermediate or long-acting. Then inject the air equal to the regular insulin dose into the vial and withdraw the regular insulin. Then withdraw the intermediate. Okay, so you put the air in that one, then you take it out and you actually drop the regular, the clear, so you go clear to cloudy, and then draw up your cloudy. Okay, clear to cloudy. Controversies. 45 or 90 degrees. Well, it depends. Depends upon the amount of subcutaneous tissue, depends upon their age, depends upon their size. Sometimes, you know, if you got a very thin person, you want to go on about a 45-degree angle. If you've got a very heavy set person, 90 degrees is going to go into the subcutaneous tissue. Use of alcohol pads. They have proven with research that soap and water is just as good. Just make sure that you're drying it, no matter if you're using soap and water or alcohol pads. And it is a little cheaper to use the soap and water. The use of the same syringe. Research supports that insulin preparations have bacteriostatic additives that inhibit the growth of bacteria commonly found on the skin. They say disregard it when it becomes dull, bent, or contaminated. So if we look on page 1435 in your book, on page 1435, there's a good visual, ABCD, and it shows the reuse of an insulin needle. A was what the end of a sharp a new needle looked like. B, you can see, look at that tip after it's only been used once. Look at the tip after it's been used twice. And then look at the tip after it's been used 6 times. Now, my grandma was one of those ones that thought that it was a sin to use her insulin syringe once and throw it away, so she was prone to use it several times. She would bruise, bruise, bruise. And I figure it's because she was using a needle that had no sharp end on the tip, because she would use them 5 to 6 times. So that's just a good visual to keep in mind with someone who's wanting to use the same syringe over and over. Disposable of needles, there's a lot of community programs out there. www.safeneedledisposal.org gives some great feedback on suggestions on disposables of needles in the community. Rotation of sites. Atrophy will occur, and it also causes erratic insulin absorption. So what they say now with rotation of sites is, like, if you're going to start with the abdomen, rotate within that area for a while, then move completely to a new area. So you can do 4 to 6 injections within the area of the abdomen, 1 inch apart. Then you would move maybe to the arm. Then you may move to the other arm. Then you may move to the leg, then back to the leg. But if you're using the abdomen, you go 2 inches around the navel area, or 2 inches from the navel area. Okay. Now remember, peak times are going to differ depending upon what area that you give it in. Okay. Absorption sites in the abdomen, that's your fastest but shortest duration. In the arm, it's very fast but shorter duration. In the thigh, it's very slow absorption but long duration. And in the buttocks, which I've never known many people to give their insulin injection in the buttocks, but it is the slowest and the longest duration. So that's just something to think about. What if you're going to be doing, think about what they're going to be doing for the day. For example, exercising before you choose your site. If you're going to be exercising your legs a lot, then you wouldn't want to give it in your legs that day, okay? Because exercise will increase the rate of absorption, decrease the time of onset, so you better be watching them for hypoglycemia. All right, insulin pumps or continuous subcutaneous insulin infusions. Who's a candidate for an insulin pump? Well, anyone who's getting multiple daily injections. Anyone who's getting multiple daily injections, particularly if their hemoglobin A1C is staying still consistently above 7. How does it work? Well, it mimics a normal functioning pancreas. Now, it doesn't detect and respond to blood sugars as well. We do have some of our newer devices that you can actually put transmitters in there and wear a transmitter. They are a sensor. It's actually called a sensor. And that sensor will detect when you have high or low blood sugars, and it will make that alarm go off and wake you up or alert you that your sugar's high or low and you need to check it. Now, people that I know have sensors that they go off a lot, false positives. But you'd rather do that than have something happen and them not know it. So they're not without fault, but they are a good thing, and technology has certainly increased. There's a good visual on page 1434 in your book of a insulin pump external. These have been around since 1970s. We just haven't used them much till recently because the insurance companies were kind of hesitant at first. But now they are finding that they're having fewer micro and macro complications because it does control the blood sugars better. So now they're coming around and paying for them. The pump is very small, as you can see on page 1434. It holds 3 ml syringes with U100 insulin, so it holds 300 units. They're very expensive, and as you can imagine, things can malfunction with the machine, and you would never want to get 300 units at one time. They can run anywhere to $4 to $6 grand, and about $80 to $100 for supplies monthly. So there is the cost factor. Boluses, how do you bolus? Well, it depends upon your carb intake because it's set up to do just basal rates. Remember we said this pancreas about every little bit pulsates, every 10 minutes pulsates a little insulin. Well, this machine mimics a pancreas, so it pulsates and sets a basal rate and gives you so much every so many minutes. But again, remember what I said when you eat. The demand for insulin goes up because your sugar's up. So you've got to have more with your meals. So what they will do is carb counting. And they will count their carbs and they will bolus themselves as needed. They'll program it in their little machine and give themselves a little bolus. Usually for adults, it's a 1 to 15 ratio. For children, 1 to 20 ratio. So for every 15 grams of carbs an adult eats, they need 1 unit of insulin. For every 20 grams of carb a child eats, they need 1 gram of insulin. So if an adult ate a 60-gram meal with carbs, how much insulin would they need to cover that? So if they took 60 grams in, divided by 15 would be 4. They would need 4 grams. Advantages and 4 units, not 4 grams, sorry. Units, the advantages and disadvantages of the units. Well, they do have tight glucose control. They're very small. They have increased the flexibility of life. Most of them have water-safe models now. It eliminates individual insulin injections. Very accurate. They do improve hemoglobin A1C levels, so the macro and macro complications will be lower. And we can use them in all ages. Okay. There is a little link there that you can watch that actually shows you more about the pump. The PEDS book, you can look in it for PEDS considerations. Motivation here is the key. Disadvantage, they're expensive. They're subject to malfunction. That tube tends to kink a lot, as you can see on page 1434. That's all wound up. And if that kinks, they don't get their insulin, therefore their sugar goes high. Requires client participation. They have to still check their sugars. They still have to monitor, make sure things are going well, and be compliant with wearing it. They can develop skin infections, and they shouldn't be removed for more than 1 to 2 hours. All right, what about the pre-filled syringes? Because we see a lot of people talking about the pens. The puncture is automatic. It is convenient and accurate, as well as easy to use. The needles are very small, 8 millimeters to 12 millimeters. Most people say they have decreased pain in injections. The disadvantages is they don't allow mixing unless you get the pre-mix 70-30. The max dose is 80 units at one time. Storage, they're only stable 7 to 30 days once they're open. And the cost reimbursement varies with the insurance companies. Now in Europe, 95% of your patients with diabetes use pens as compared to only 5% of the U.S. with diabetes. Why? Well, the reason is in Europe, if you have diabetes, you usually go to a diabetic specialist or an endocrinologist. In the United States, most diabetics go to their general practitioner, and they have a socialized medicine system as well. So that's the reason. Jet injectors, we don't use these much. They don't have needles. They deliver insulin under pressure, kind of like you get your injections in the Army. Expensive, they require extensive training, a lot of bruising, and absorption varies. So we just don't use it. Now, inhaled insulins, we've been trying to use these, not use these. Exubria was one of them that was on the market, but it was withdrawn due to low adoption rates and poor sales. Because it really only covers meals, not basal rates. So, and there's other inhaled insulins that are still in the clinical development stages that they're going to try as well. So that's something that they're looking at. All right, type 2 treatment. The emphasis here is on medical management in type 2. Diabetes mellitus focuses on blood sugar, lipids, and blood pressure controls. Therefore, it involves 3 factors: diet, medications, and exercise, and you need all 3 to be compliant with your treatment with type 2 diabetes. The use of oral hypoglycemic agents meant to supplement diet and exercise, not replace them. In other words, you don't pull up to Dairy Queen and get a huge peanut butter parfait and go home and take your metformin with it and think everything's going to be hunky-dory. Probably not going to happen. Targets of your oral hypoglycemic agents: fasting between 90 and 130. The postprandial blood sugar less than 180. And your hemoglobin A1C less than 7% would be a target of what you would want with a person who is on an oral hypoglycemic agent. That's the targets. The diabetes management is monitoring your ABCs. Now, our ABCs with diabetes stands for A, hemoglobin, A1C, or glycemic control. B stands for monitoring and controlling blood pressure. And C for cholesterol or lipid levels. Oral hypoglycemic agents. Your first generation sulfonylureas are your long-acting, 24 hours. This is your oldest class of drugs. We don't use these as much because we have all these newer drugs out. And they're tolerated much better. But the way that these work is they increase the sensitivity of insulin, therefore stimulate the release of insulin from the islet cells. You have to use caution. They can cause hypoglycemia, people with liver and kidney problems, because they're metabolized in the liver and excreted in the kidneys. Common side effects is GI disturbances, rash, nausea, fullness, heartburn. Hypoglycemia is a big one, and these you have to take with food at breakfast. Weight gain are common with the oral hypoglycemic agent, so most people don't like to take them. So how do you decide what's best for a patient? Well, a physician has to look at a lot of things when they're ordering oral hypoglycemic agents. They have to consider cost. They have to consider the person's age. They have to consider their response. They have to consider if they have a history of kidney or liver problems. So there's lots of things they consider when they are ordering these treatments. Examples of your first generation sulfonylureas you can see here: Diabinase, Oronase. These are all, again, taken with food. They are long-acting. They're the most durations of these last up to 24 hours, but Diabinase is 24 to 72 hours. So what's the implication for the RN? Be careful with someone who's taking Diabinase. Make sure you're monitoring their blood sugar carefully. One of the things my sister went to the hospital, and she was an OB patient, and we know that OB patients, sometimes their sugar drops a little, and she was on Diabinase, and they had given her Diabinase, and so she had a hard time monitoring and keeping up with her blood sugar. Okay, second generation sulfonylureas. Their action, they're same as the first generations. They are more expensive but fewer side effects. But they're not as hard on the kidneys and less drug interactions occur. Now, I call these the Gs, or the long-actings, because most of them start with the letter G. The duration is about 24 hours. This would be like your glucotrol, your Macronase. This one you take a half an hour before meals with food and with food. So if you're on glucotrol, you take it before meals, and the other ones you take with food. Okay, your bicarbonatides or your intermediate actings, these reduce hepatic glucose production, and they boost sensitivity in your muscle, fat, and liver. The bonus for taking these is that they decrease triglyceride levels. They are not metabolized by the liver, but excreted by the kidneys. Okay, so these are good for clients with significant obesity. Renal insufficiency leads to lactic acidosis. Side effects: diarrhea, so you want to take them with meals. Example would be metformin, which is a lot of people are on metformin, okay, or glucophage. Duration is up to 24 hours. Can cause drowsiness, and when you first take metformin, it causes lots of GI upset. You'll be in the bathroom a lot. It should be stopped before any surgery or procedure requiring a contrast dye, and then restarted 48 hours afterwards because it can cause problems with renal function. Usually they'll start 500 milligrams once or twice a day and max up to about 2,500 a day. There is a drug alert about metformin on page 1428 in your book that you need to look at as well. Okay, the alpha-glucoside inhibitors are your starch blockers. These facilitate insulin's actions on the peripheral receptors. They interfere with GI absorption of the carbs, so they delay it. And they give the pancreas then time to secrete insulin to help keep the postprandial blood sugar levels down. So if you've got someone who's running really high 2-hour postprandial sugars, these will be the best choice. They decrease postprandial blood sugars, but they do have some bad side effects, a lot of tooting and pooting going on, and abdominal pain. Precoce and Glycet are your common ones, and they have a duration up to 8 hours. Okay, these are not tolerated well by some people because of the side effects. Okay. Your TZDs, they increase the receptor sensitivity to insulin and decrease lipid levels. They're metabolized in the liver, excreted in the feces. Side effects: cold like flu, headache, anemia, fluid retention, and weight gain. So you want to be very careful with someone who has CHF and they're on a TZD. Can be taken with food. This would be like your Actos, Advadia, and we've had a lot of people had a lot of trouble with Actos. Duration is unknown. We think it's up to about 24 hours. Okay. Your megalitides analogs are your increased insulin secretion, and they prevent post-meal blood sugar elevations. This would be like your Starlex, your Prandon. You take them 30 minutes before meals. You omit the drug if you're skipping a meal and add if adding a meal. And you watch for hypoglycemia. One of your newer meds is your Januvia or Onglyza. That's the competitor. Same thing. This is your DPP-4 inhibitors. These are usually taken once daily, along with diet and exercise. They help lower blood sugar levels. Okay, a lot of times people will take these in combination with metformin. They're not associated with weight gain and reasonably well tolerated, and they have been approved to use with either monotherapy or with other ones such as your metformin or a TZD. Now you do have to watch for pancreatitis, abdominal pain, nausea, and vomiting with this one. Your non-insulin polypeptide analogs, there are 2 injectable analogs that were approved by the FDA in 2005. And these are your, if all else fails, order the combos as well. These we don't give unless we just have to give because they do have some side effects. They come in micrograms, so you have to convert them to units, and because of that and the trouble with that, people have had trouble. They're not compatible with other insulins. They don't mix well with other things, pills, so it's just better try not to give those unless we have to. And then you have your combos where you can get your metformin with another type of medication. Okay, actually, your non-insulin polypeptide analogs have what we call a black box warning. If you don't understand black box warning, you can read up that on page 1429. So overall precautions, regardless of what oral hypoglycemic agent you're taking. Using caution with clients with kidney diseases or liver problems. Watch for allergies to sulfonamides, so you wouldn't be able to give them the first or second generation sulfonylureas. Watch for alcohol with oral hypoglycemic agents. It can cause an antibutyl-like effect and some other affect the blood sugar, and we'll talk about that in part 3. You want to watch for interactions with other drugs, example like steroids, and remember that the duration varies. So a mnemonic to remember is hot and dry, sugar's high. Cold and clammy, you need some candy. All right, that's the end of part 2, and I will be getting and trying to do part 3 here in just a little bit. One of the newer drugs that's out is called Invokana. And Invokana is the new kid on the block. And how Invokana works, it's an SLL, it's a sodium glucose co-transporter, and it is a SGL2, and it works by blocking the kidneys, okay? And what it will do is keep the kidneys from reabsorbing the glucose so that you excrete it more. So you excrete more of the glucose by working on the kidneys. Now, the bad thing about that is that you may have more urinary tract infections and yeast infections and itching and other things along with that. But that is the newer one on the block. Research shows that it does help keep those hemoglobin A1Cs down at least a full percentage in most diabetics that are compliant with that. All right, thank you and have a good day.